So hi, everyone. My name is Scott Allen. I'm the CEO for the Family Medicine Education Consortium. Thanks for joining tonight for our Hot Topics in Family Medicine with the Geisinger Lewiston Rural Family Medicine Residency Program. And thank you, Dr. Frank Dixon, for being here to talk with us tonight. Before we jump into that, I'm going to give just a little bit of background on the FMEC. So for those of you who don't know, we are a regional coalition of 14 states and the District of Columbia. In that region, it's the Northeast US. We have about 60 medical schools and 190 family medicine residency training programs. So we like to work with as many of those as possible. We do an annual meeting each fall. It just happened about 2 weeks ago. Hopefully some of you were there. Very successful, about 900 people, including 89 family medicine residency training programs in our residency fair. So it was a great opportunity for medical students to meet with the residency programs and learn more about them. We also do awards. We do learning collaboratives around topics such as integrative health. We have a new one coming up on breast and ovarian hereditary cancers. And we like to engage residents, medical students, and faculty in many other ways if we possibly can. We are a catalyst, convener, and incubator, and really our three core priorities are to introduce medical students to the field of family medicine and primary care and hope that they go that pathway in their career. We like to support residents in their training, but also help them transition out into careers by learning about everything from different practice options to how to manage their student loans. And we like to strengthen academic family medicine residency training by helping faculty connect with each other, get experience presenting and talking about new and emerging issues through our meeting and through other activities. So with that, just one more quick plug. If you didn't make it to Arlington, Virginia last week, or 2 weeks ago, please consider joining us in 2023. We will be in Providence, Rhode Island, October 13th through the 15th. And we will again be having scholarships for medical students, but also opportunities for residents and faculty and others to present. So with that, I would like to turn it over to Dr. Frank Dixon.
Thank you. So let me pull up my slides here. And then okay. Can everybody see my slides? Yes, yep, I see a thumbs up. Okay, thank you. Just to introduce myself, I am a family medicine physician and I work in rural, like central Pennsylvania, and I'm the assistant program director with the Geisinger Lewiston Rural Family Medicine Program. And very involved in advocating and promoting health for our transgender and LGBTQ community in rural Pennsylvania. So I've just put together a presentation tonight about gender affirming care, and I'm just going to give an overview of sort of the latest and greatest in the current standards of care in this field. And I'm a pretty informal presenter, so if anybody has any questions as I'm going, please feel free to just go ahead and ask questions as I'm talking. So just an introduction to what I call the alphabet soup of LGBTQ plus care, because there's a lot of letters that we talk about. Just the just kind of pointing out that we're talking about that alphabet soup comprises a lot of different things. So it comprises both gender identity and sexual orientation, which are really two very separate things, separate concepts. So the LGB refers more to sexual orientation of lesbian, gay, bisexual. The T and the Q get more into gender identity. So that's more of an internal feeling, an internal identity of who somebody feels they are. So the T is describing transgender individuals, typically transmasculine, transfeminine. The Q can refer to either queer or questioning, somebody who maybe feel they just don't fit into a box or haven't figured out exactly how they feel most comfortable quite yet. The letters can go on. Would be intersex, and it goes on and on and on. But this is, that's just sort of an introduction to the alphabet soup. Taking it a little bit further, just that there's a lot of different nuances to how people may feel about themselves, identify personally themselves, how they may present themselves to the external world, and how they may feel attracted to other individuals. So, and all of these different aspects of an individual's identity don't necessarily correlate. So the sex is really the chromosomes, the biology of the body, and whether the chromosomes are XX, XY, the body presents as a masculine, feminine, or intersex. That's really looking at the biology. The gender identity is something that's really occurs in the mind and how somebody identifies in terms of their own personal identity in relation to their gender or to not having a gender. So cis is sort of the opposite of trans. So that would be the majority of people would fall into the bucket of feeling cisgendered. So I would describe myself as a cisgendered woman. I was born as a female and I identify as a female. That feels right to me. As compared to somebody who would identify trans, where they were assigned, let's say, masculine at birth, but they really identify feminine. And so that's the kind of clarification of those two categories. And then non-binary would be somebody who really feels they don't fit into the masculine or feminine box. They may feel they have elements of both genders and feel bigendered. They may feel non-binary and they really don't fit into either box, and gender is just not a big part of their identity. And then there's the gender queer, and I call it, that's sort of the everything else, people who feel that they're somewhere along that spectrum of gender identity and not really at one end or the other. Gender expression is, again, very different. So the way that somebody feels internally and what feels right for their own identity may be different than how they appear on the outside. So for, let's say, a trans feminine person, maybe they're not out yet, right? And maybe they don't feel comfortable coming out, for example, at their doctor's appointment. So they may identify female on the inside, let's say, but they may appear masculine on the outside for different reasons. And so this can apply to somebody's dress, hairstyle, mannerisms, speech, a lot of different ways that somebody may present. So just a point to not make assumptions about people because of the way they may look. And then the sexual orientation is really a very different concept, and that's really considering more how somebody is attracted to other people, right? So heterosexual would be the majority group of people who are attracted to an opposite sex. Gay typically refers to men feeling attracted to other men, lesbian women attracted to other women, bisexual to both. And then there's a lot of other elements that particularly younger people are using to describe themselves. Feeling asexual, people who are just really not feeling a sexual attraction at all, and that's just not part of something they identify with. Pansexual is a term I'm hearing more and more in younger people in particular, but people who just feel that gender is really not a big part of what attracts them to somebody else. And so they may describe themselves as pansexual, somebody who could be attracted to somebody who's male, female, non-binary, trans, anything in between. And their attractions are really based more on other elements of that person's identity. So, and just to say that these things are not necessarily correlated. So you can take any category in this and say somebody who has a sex of male, but they identify as non-binary, maybe they're presenting in a very feminine way, and their sexuality is asexual. So like any of these, you could draw like a horizontal line connecting any of those different categories to describe a variety of people. They don't necessarily correlate. They usually don't correlate, actually, they often don't. So how do we describe these things clinically, right? So when these patients encounter a healthcare system and we're providing medical care for them, we have to come up with coding and billing and more classification of what these identities mean and whether or not they warrant medical intervention. So there is, as with everything in medicine and science, like things are always evolving and changing. And so we're sort of in the transition between the ICD-10 codes and the ICD-11 codes. And in terms of the gender dysphoria or gender classification, so there's an interesting shift where it's going from the F64 code, which was described as gender dysphoria, which was categorized in mental and behavioral disorders, right, as something that was described as a pathology that warranted fixing or medical treatment, medical intervention. ICD-11 is encompassing sort of a paradigm shift in how we're looking at gender variance, the gender spectrum. And there's a whole new chapter now in ICD-11 that's titled Conditions Related to Sexual Health So not necessarily a mental health disorder. And it's we're now using the terminology gender incongruence, which is affirming to a lot of individuals, because a lot of trans individuals don't feel dysphoric. They're very happy to be their gender identity that they have. So there are new codes that are trying to capture that and reflect that. In the field of psychiatry, so we have the DSM-5, and that's where that's where we go to still to come up with sort of what are the diagnostic criteria where somebody might qualify for or warrant, might benefit from intervention or treatment. And so in the DSM-5, what we're really looking for is a marked difference between the individual's expressed or experienced gender and the gender that others would assign to him or her, or the gender that was assigned at birth. And that experience or expression or identification should be present for at least 6 months. And in children, we look for that to also be verbalized by the child themselves. So those are sort of the medical definitions. Does anybody have questions? Okay. So I'm just going to jump right into children, because I feel like this is the touchy spot and where people get nervous or feel uncomfortable about transgender individuals or medical aspects of care, because how can children know who they are? How can they make such life-changing decisions for these very young people? Well, the reality is that we don't, right? A lot of children do explore and role play in a variety of ways. Some of those children persist into adolescence and adulthood with gender incongruence. Some of them don't. The bottom line is there is no intervention beyond supporting that child to explore who they are and feel confident about who they are. There's really no medical intervention that's warranted before puberty, right? So there may be interventions that would comprise like family support, that might comprise allowing that child, supporting that child to perhaps try different names or different pronouns or different clothing, or perhaps work with a behavioral therapist to help the family understand and better understand this child's exploration and their identity. But there are no medical interventions or surgical interventions that are ever recommended in childhood. So the WPATH standards of care. So the WPATH is the World Professional Association for Transgender Health, and they really set the gold standards for care in this population. And they just released their updated standards of care. It's version 8 about 2 weeks ago. So this is sort of the latest and up-to-date guidelines. So in early childhood, it's really just to support their gender role exploration and support a social transition if that seems warranted for that child, if that seems to be what would benefit that child. Again, no medical intervention, no prescriptions, no surgeries. So we look at identity versus exploration. So how do we sort of, as a clinician, start to look at that child and try to better understand them so that we can meet their needs? How do we start to identify whether that child is truly trans, or are they exploring and figuring out who they are? So we look for these 3 factors. Is it consistent? Is it insistent? And is it persistent for at least 6 months? Most of the kids who come in later presenting to the medical system, in my experience, have been consistent, insistent, and persistent for many, many years before they would show up in my office for care. So those are the 3 key factors that we look for as being established for a minimum time period of at least 6 months. So then the child grows up, right? And now they're entering adolescence, which are defined as the start of puberty. So when they reach 10 or 2. So I'm just presenting the old guidelines, standards of care 7 compared to standards of care 8, because standards of care 8 were really just released about 2 weeks ago. So the old school way of defining things and laying out the roadmap of care was age-based and developmental-based. So puberty blockers were not considered until a minimum of age 12, and once the child had reached at least Tanner stage 2 to initiate puberty blockers. That would be like a GnRH analog. Cross-sex hormones, so introducing estrogens or testosterone for transgender adolescent, really was not recommended until age 16, and surgical approaches not until at least age 18 and a full year of being on cross-sex hormones. More conservative guidelines, I think, came out. These guidelines, I believe, came out in 2017, and this is the standard of care that we've really been practicing under, for years. So more recent, the updated guidelines look really more at developmental readiness and individualized care, realizing that not all adolescents and children develop at the same rate. Not everybody hits Tanner 2 at age 12, to allow more individualization of care. And so now we're really looking for sustained identity over time, authenticity versus gender. So what that's getting at is not everybody falls into a box, and the more people are presenting and feeling comfortable coming out as trans or non-binary, we're finding that there's a lot more people who really don't put themselves into one box or the other. So a lot of that is trying to come to an understanding with your patient about what is their authentic identity for them, because it may not be exclusively male or female. We look for maturity to consent, to particularly less reversible interventions. We look to see that their mental health concerns have been addressed if there are any, right? So again, separating a mental health disorder from a gender incongruence, because the two don't always occur together. We look to make sure that fertility options have been discussed, because in an adolescent, when you do initiate puberty blockers, so for years we have considered that to be a reversible treatment. We can pause puberty, allow the child to sort out what their true identity is, because it's true, if puberty blockers are initiated and then stopped, fertility would then return. In a trans individual who is going to continue on and transition, you don't typically stop the puberty blockers. You transition to cross-sex hormones. And so there could be an irreversible fertility impact to that individual where they could become infertile. So that needs to be discussed. Sperm banking needs to be discussed, cryopreservation, all of those things. And then we also look for Tanner 2. So just that initial signs that puberty has actually begun would need to be confirmed before any medical intervention would be considered. So why not wait until age 18? So this is, I think, something that's being discussed more politically and a little bit of a hot topic. For people I think, who are raising trans children and who are involved in the care of these children, it's very obvious. Why not wait until age 18? Because a lot of harm and trauma can happen in those years. There are simultaneous processes of development during adolescence. As we know, those are difficult years. Those are we go from being children to being adults to figuring out our adult identity. There are physical changes, there are emotional changes, social changes that become more important weight and importance is put on that social group and those social relationships with peers. There's psychological changes that happen. It's a very critical period during adolescence. And naturally, all of these different processes happen simultaneously. If we delay medical treatment, if we delay transition until age 18, until that child has become an adult, that creates a lot of stress, that creates a lot of trauma, because you're separating the physical development, the social development from the other aspects of development, and you're separating them from their peers. And we typically see worse outcomes in terms of depression and suicidality. The peer group element is a very important thing in this age. And so that's really the answer as to why we don't recommend waiting until they're 18. So just moving up in age, so moving up to the recommendations for an adult, so somebody age 18 or plus, or Tanner 4 or 5 plus. So there used to be a lot of recommendations of formal assessment with psychology, sometimes multiple psychologists, to really determine that person's identity as if they don't know that themselves. Now the recommendations are that it really comes down to the doctor and the patient, and that the doctor helps that patient just determine what is the best plan of care for them. Aspects of gatekeeping where people previously had been asked to have multiple psychological assessments before they could be eligible, so to speak, for hormonal or surgical intervention. So that's largely gone away, largely because science has shown that that's not necessary. When people were previously asked for multiple letters of support from multiple psychologists, all of those letters were typically the same. And so there was really no benefit to the patient to ask them to have them undergo that level of evaluation. With very patient-centered risk consideration when it comes to mental health considerations, comorbid conditions, and just their general readiness for transition. Are they in a good place in life to undergo this huge life change? And that we generally recommend maximizing hormonal treatment prior to surgical procedures, particularly if the hormonal treatments will lead to the physical outcomes that they're desiring, for example, breast development. And that is only, again, patient-centered if that particular patient desires hormone treatment. Not all patients desire that. So I'm very, very, very happy with the updated standards of care because it's very patient-centered, which is really how most of the rest of medicine and medical care has evolved. It's very patient-centered. We try to do the best for our patients based on what is in their best interest. So moving on. So these are adolescents who have been supported to transition during their adolescent years. So why is this important? I like to just look a little bit at the epidemiology. So my driving, reason why I feel strongly and passionate about providing this care is at addressing the really high suicide risk and high suicide rate in this population. So it's pretty well studied and sourced that transgender population has very high depression and suicide risk. About 41% is a statistic that's quoted by a lot of different research groups. 41% attempted suicide, lifetime suicide attempt among untreated individuals with gender dysphoria. Compared to the regular, put everybody together, the statistic on that is about 1.6. So a huge, huge, huge difference. That rate of suicidality goes up from even above higher than 41% if that individual has been bullied, harassed, if they've been physically or sexually assaulted, which they're at much higher risk of those types of assault. Much, much higher rate of murder in the United States. And why is that? Because of all of the external social, physical factors where a lot of these individuals have been discriminated. They have been rejected from family, jobs, housing, a lot higher incidence of what I consider maladaptive coping strategies like use of drugs, tobacco, alcohol, things like that. This is looking at the political landscape. So in 2015, there was a national survey done. I think on my next slide, I remember who it was. Just a survey of people who identify as transgender and non-binary. And as part of that, we looked at the political landscape. So this map is showing which states have non-discrimination laws in place for sexual orientation and for gender identity. So the gray states, which is most of the states, including the state where I live and practice, Pennsylvania, there are no laws currently that protect individuals, no state laws that protect individuals against discrimination on the basis of sexual orientation or gender identity. The blue states, so Wisconsin, New York, they do have laws in place to protect people on the basis of sexual orientation, but not gender identity. The purple states do have laws in place that protect individuals on both levels. So there's a lot of vulnerability in this population from a legal perspective. In the state of Pennsylvania, as far as I know, so we do not have great laws or supports for our young people in particular. So Medicaid currently is not covering transition-related surgical procedures. They do usually cover hormonal interventions. And the ACLU is advocating for our young people, for our transgender youth. So this results in our patient population. So what does this mean for us as doctors and clinicians? Is that we need to be mindful and aware that our patients are vulnerable when they come and see us, and there's a lot at risk on the table, right? If they are outed, they could face serious consequences for that. They fear that when they're sitting in the waiting room and they got called back, there could be a mismatch in their name and identity. That can be a very uncomfortable experience, or they could actually lose their job over it potentially. They fear being asked non-medical or personal questions, and they fear obviously just being denied the care that they're seeking. If they're ready to transition and they're seeking gender affirming care. So it often takes quite a lot for an individual to step up and make that appointment to seek out this care. So I believe in the good in people, right? So why are there so many primary care offices that turn these patients away? Like the doctors I work with are phenomenal physicians and don't intend to hurt people, right? We all went into this because we want to lift people up and help people with their health and their lives. And I think it comes down to the Hippocratic Oath and a lack of training in medical school and residency, right? We have all taken an oath to do no harm. And so if a patient of mine came to me with a brain tumor and they needed that surgery to have it removed, am I going to offer that to them? Heck no, because that's not my training, right? And I would obviously feel like I was putting them more at risk. So lack of familiarity and training is scary. I think there's also an assumption that there is another field or specialty out there that does have this background in training. There are some endocrinology offices who do offer this training, who do offer these services, but not a lot. Most of this care is being provided in the United States by primary care physicians, usually family physicians nationally. And I would argue, so I was kind of nervous when I was asked to take on this care, and I very quickly learned that I didn't realize it, but I did have the knowledge and the skills to provide this care to my patients. I just didn't apply it in this particular context. So it's actually a lot more manageable and doable than we may realize. So a lot of it comes down to, so the golden rule respect. So this is really just about, so there's different elements of providing care to this population. And one big one that I think everybody who is involved in healthcare needs to understand is this, what does it mean to be affirming? What does it mean to treat our gender diverse patients with respect? What do they want from us? Not a lot. They just want to be recognized for who they are, and they want to feel safe in our clinic spaces, right? So if a patient comes out and says, hey doc, I really needed to tell you I'm trans and I'm just coming out to my family and friends and I need you as my doctor to know that, So what do you say? Thank you. Thank you for sharing that with me. What does that mean for you? Where are you at in your transition process? Be open to having this conversation with your patients and help. If you don't provide the care yourself, then refer them to somebody who can help them hormonally. I think we do bear that onus of responsibility. I think also, so identify your clinic as LGBTQ friendly if it is an LGBTQ friendly place, with signs, with pronouns. I mean, just wearing your own pronouns on your badge shows that you are a safe person to talk to and to come out to. It also clarifies what your pronouns are. If somebody tells you what their pronouns are, then use them, right? So like, for example, if there's a teenager in my office and they're trans male and maybe they're there with somebody who really hasn't fully accepted that, but they tell me that they're male and they tell me that they prefer he, him pronouns, when I'm talking to that person, I use their preferred name and pronouns. Just the simple act of affirming that person's identity by using their preferred name and pronouns decreases depression rates significantly. If you don't know somebody's gender, then don't out them, right? If you go out to the waiting room to call Jane Smith and you only see somebody who looks like masculine, then you just say patient Smith, right? We don't need to make our patients feel uncomfortable. And another big thing is to not ask questions that are really not relevant to why the patient is there. I have more patients that have been asked inappropriate questions probably than I have who have not had that experience. A patient perhaps who was in a car accident and they broke their arm and they're in the emergency room for their broken arm and they're being asked, have they had any genital surgeries to support their transition. It's really not relevant, and we don't need to ask those questions. It's traumatizing. So providing that affirming environment is really a huge part of what all of us should be doing, and recognizing that gender diversity is part of human diversity, right? And underneath all of our exteriors, we're all more similar than we are different. I apologize for the barking dog. Sorry. So healthcare goals. So the big one, I would say, provide that gender affirming environment, provide appropriate primary health, recognize what that patient may need, right? Think about this for a minute, but I have male patients who need pap smears. Okay, so you have to think about an organ system. What does my patient need? Consider their mental health needs, if there are, and be ready to have conversations about hormone and surgical procedures if that patient wants or needs those things, and either provide them yourself or know where that patient can go to get those, to get that care. So what's the nitty gritty? So what are we really talking about here? So we're talking about hormones and blockers. It's really not as complicated as you may think, right? For a transmasculine patient, there's really one prescription that will masculinize, and that's testosterone, right? For a transfeminine patient, it's two things. It's one, suppressing like endogenous testosterone production, but it's also introducing that estradiol to feminize. We use finasteride, we use progesterone, but the big things that we need are the spironolactone and the estradiol, or androgen blocker and the estrogens. And in kids, it's really looking at the GnRH analogs like leuprolide, and then later on the testosterone and the estrogens. So I put this up there because a lot of doctors will say, well, gosh, I've never been trained how to do that. But most of us actually have prescribed most of these medications in our careers, right? For hypogonadism, for liver failure, for blood pressure, for hormone replacement therapy. The puberty blockers, maybe not as much, I understand that, but the other medications are things that we use and are pretty comfortable with. Oh gosh, what happened to my slides? Here we go. So just for understanding, so when we talk about surgical interventions, this is often referred to as top surgery or bottom surgery. Top surgery is really looking at transmasculine individual having a mastectomy with a masculine chest reconstruction. WPATH used to recommend the 12 months of hormone therapy. That has really gone away, and it's really looking more at what's most appropriate for that individual patient. So for a transmasculine person, so this would be somebody who was born with female biology, female body, who identifies masculine. So we're looking at chest reconstruction, sometimes hysterectomy with oophorectomy, and sometimes metoidioplasty or phalloplasty. I would say those surgeries are not as sought after. Metoidioplasty is really just construction of a very small phallus that essentially allows an individual to urinate standing up. For a trans woman, so again, this would be somebody who was born with boy body parts, but really is a woman and identifies female. So in terms of surgeries, vaginoplasty is bottom surgery that we're talking about. Sometimes breast augmentation, tracheal shave, or hair removal. So those are the surgical interventions that are most commonly sought after. So, and I put this up there as like the don't throw the baby out with the bathwater, so to speak. The bulk of the care that our patients need is primary care, right? That's the bulk of our care that our patients need, but it needs to be thought of appropriately for that particular individual, right? So like I said, I have male patients who have transitioned, right? But they still have a cervix, right? So we still need to have a conversation about cervical cancer screening. I have male patients who still have breast tissue who may need mammography. I have female patients who maybe have undergone vaginoplasty, but they still have a prostate, right? So we still have to have those conversations and the everything else, right? Just because somebody's trans, that doesn't necessarily have to consume all of their medical care, right? They may just be coming in to see you for diabetes management or depression management, and we don't have to focus on the gender identity as their main issue all the time. So what are the risks of treatment? There's very few. Really, the Big ones that WPATH talks about would be a current cancer really that could be aggravated by introducing some sort of treatment, right? So if somebody had testicular cancer, ovarian cancer, you probably don't want to introduce sex steroids at that moment. If somebody has a recent pulmonary embolus or a DVT, it's not a great time to introduce estrogen. So those are our cautions. And then the fertility issues. So that's always that's an important conversation to have, is what is that person's what are their plans for fertility? Is that an important aspect that we should address before we introduce hormones? Then I always talk about like the need for shared decision making, and transgender care. Hormone therapy is a newer element of medical care. And so there's a lot more research. There is a lot more known now than there was even 3 years ago. But there are risks of, there are things that we may not know, and we may not even know that we don't know them yet. So just acknowledging that when going through informed consent, I think is still very important. What are the benefits? So the huge benefit is that suicide attempt rate drops from 41% to 1.6, which is life-saving. This is life-saving treatment. Huge improvement in quality of life, and having an appearance that's congruous with someone's identity means someday can pass and they can use the appropriate restrooms, and they won't be necessarily harassed, or abused or discriminated against. So this is one of my favorite slides in this talk, just about the number needed to treat. And just putting this into perspective with some of the really common medical interventions that we all very widely use and accept. So just comparing gender affirmation care to statins, mammograms, cabbages, antihypertensive therapy, right? So providing gender affirmation will prevent a suicide attempt out of every 2.5 people who are treated. That's huge. That's a hugely effective medical intervention, and will save the life of 1 in 63 patients who would have otherwise died from a suicide death. So it is life-saving care. It is important. This is not cosmetic, and it's not a choice. This is very important and very doable medical care. So I throw this slide up there. Jazz Jennings is a TV personality. She had her own reality show. Her family had cameras and they followed them around, and she was a trans teenager who went publicly to advocate for trans kids and gender diversity. So, and I put this out there because I think it's pretty clear that this is a social revolution of sorts, that being transgender, LGBTQ is being talked about and accepted much more broadly. And there's a lot of advocacy for health equity in this group of people. And there's a lot more recognition of this patient population. And so I think it's something that as a medical organization, as a profession, we sort of need to recognize their specific healthcare needs and step up to the plate so that we recognize and affirm and provide the same level of excellent care to this group that we do to everybody else. And this is my last slide, just where I get a lot of my information. The top two, WPATH and UCSF Transgender Center of Excellence, have great websites with fantastic resources for clinicians, down to the most up-to-date standards of care, all the way to the specifics of how do I manage my trans feminine patient who just developed a blood clot in her leg. Fenway Institute has great trainings that's associated with Harvard University. And LGBTQ health education and National Center for Transgender Equality also have a lot of fantastic information and data and education on their websites. So great resources are available. And that's the end of my presentation. So if anybody has any questions or comments, we can open it up for that.
Thank you so much. And if you have any questions, just go ahead and unmute yourself, or if you want to raise your little hand on the Zoom platform, we can also call on you. I see Kieran's hand might be up.
All right, I
Okay.
was just applying just to say thank you.
Yeah, you're welcome. Thank you so much for attending. Pranali, did you have your hand up?
Yes, yes. So thank you so much. I'm a student at the Rutgers University at MPH program, and my concentration is LGBTQ health. So we learn a lot of things, even amongst our classmates, that how much it affects them when they don't get the expected care. And they really want the, and I used to think that as primary care providers, we do everything that we want to do for our patients, right? We don't fall short of anything. But from their perspective, it is not like up to the mark. It is not what they expect it to be. So from this session, at least it helped me bridge that gap of what they want and what it is that we should try to achieve in our practice. So thank you so much, Dr. Frank Dixon. It really means a lot, for at least for me as an MPH student who's like trying to understand what LGBTQ health is. Also being an international student, there's a huge gap in my education, but this is really going to help me now during my classes as well as in the future.
Awesome. I'm so excited for your research. Where did you say you're doing your MPH?
It's at the Rutgers University in New Jersey.
Oh, that's fantastic.
Yeah.
We need more research in this area. Yeah.
So
That's
one of my research, recent literature review that I'm working on is the knowledge and the primary care providers have about LGBTQ health, and if there is an inclusion of a structured curriculum and the hours that they have spent learning, residents have spent learning about LGBTQ health. So it looks like on the residents' perspective, they do want that the LGBTQ health curriculum to be included in their program, but there are not many competent faculties in the program who are like trained to provide that training and to like teach the residents. So I think there's that gap, but if there are sessions like the one that you've conducted, probably these are going to be good foundations or starters for that discussion, and then slowly and steadily more of that curriculum can be included even not only in graduate medical training, but also during in their medical school training. I think that would be a great foundation to build on.
Totally agree. I totally agree. So a couple of things that makes me think of is I was just reading some research recently about, and I think I've seen this cited in a couple of different places, but about 30% of our LGBTQ patients report that they have felt like they had to educate their doctors about the care that they need. 30%, which is a lot. And I was looking at another one about like basically like residency education, graduate medical education, and interest among learners, medical students and residents, and comfort among faculty and residency program directors in incorporating this education into the offerings. And a lot of it comes down to, what I took away from it anyway, was that there's a lot of interest and a lot of willingness. Mm-hmm. And a lot of the barriers are that the faculty are from a generation where they didn't have this training. And so that's really their major barrier to being able to provide the training to the younger generation, is that they were never trained themselves. But they recognize that it's important and they want to start to provide this. So I think we're at a turning point where we are going to see more education in these areas being rolled out into residency programs. Yeah. And actually, I think it is part of the GME requirements now for family medicine, which is fantastic.
Yeah. AFP also has this, like, it's endorsing the recommendation of LGBTQ curriculum inclusion in the GME programs. So yeah, I think that's also a good way to start.
Yeah, we're making headway.
Thumbs up to that.
Yeah, thanks for your work. I'm excited to hear that you're interested in this area. That's phenomenal.
Yeah, I think a lot of that comes from, like, I have been working in communities even back in India where I come from. So of course, it was quite recent that India just legalized gay marriage and everything. So we are far behind that. So I think coming into a program that also focuses into LGBTQ health and then coming in family medicine would give me that head start to have that foundational knowledge, and then like I'll be able to give better service to my patients when they are there.
Totally agree. Well, it's really nice to meet you. Thanks for your comments.
Thanks.
Hi, Doctor. I'm just going to add to the accolades because I feel like what you've done this evening is to, my name is Yemi, and what you've done this evening is to remind us why family medicine is important. Like, we care about people, and we say we care about all people from cradle to grave. And so if any specialty should be inclusive, it should be us. So thank you for your work, and also grateful for the AFP recognizing the need to ensure that we get trained in this, trained to take care of this population. And again, it's just wonderful to be part of all that is going on right now. So thank you.
Yes, that's an excellent, I love the way that you phrased that because I have the same sentiment that I really feel this care belongs in family medicine. I think, I mean, other specialties can and should provide this care, but you're exactly right that we are the home for everybody. Everybody is welcome in family medicine from cradle to grave. And any personal characteristic, like everybody is welcome in our clinics, everybody. So an excellent comment. Yeah. Thank you for that.
I have a contribution to make. Hi, my name is Olamide, and I have OB background, and I have an opportunity to work in transgender clinic in the United Kingdom. And I know while discussing with them about fertility options prior to surgery, I know sometimes we do like maybe offer them if they want to freeze their eggs before the operation. I don't know, is that part of what we do here? Do we like give them options like, do you want to freeze your eggs before you do the operation? Or, I mean, what are the future plans for fertility for such patients? So I know there were some discussions around that line, and some of those patients do oblige, and some would say, no, I don't want, you know, something like that. And also, I also have an experience with a patient that actually had, he had a gender reassignment surgery. I mean, was a female that was turned to a male. And then he was not satisfied with the operation. And then, I mean, it caused a lot of, so I mean, psychological issues, depression. And I'm like, how can we help such patients? I mean, the surgery is done already, and the patient was really, really down. And though I left that clinic, so I don't really know, I mean, I didn't follow up with the patients. I don't really know what happened thereafter. But in such a situation, if you have somebody like that comes to the clinic, and I mean, how do we like help the patient follow up and help the patient acclimatize with the new look or accept the new? Do you understand what I mean? I mean, how do we help? Yeah.
Yeah, well, I think you mentioned a couple important things. I mean, so you were talking about what does it mean to address their fertility?
Yeah.
Is it more? And yeah, the big thing is having a conversation, you know, that certain interventions are essentially irreversible, right? Surgical or hormonal. And just acknowledging that fertility could be lost, and having a conversation whether they want to do, like, freeze their eggs or sperm bank. That's really the big thing. The other conversation I have with people is, you know, even if they don't, maybe they can't afford to do sperm banking or freezing their eggs. And if they want to contemplate, you know, fertility, preserving their fertility options, there's a lot of different ways to transition, right? And so it doesn't always have to involve hormones and surgeries. There are other ways of doing that. And so it's really having those deep conversations to help figure out the right path and individualized path for that particular individual. And behavioral health is really fantastic. Having a behavioral health provider who's done like the WPAP trainings or the Fenway trainings, and they really kind of understand all those different aspects of the decisions, I think is really important. You know, there's been some also really high profile like men who've gotten pregnant and given birth. Those are typically trans men, but I always say like that's not guaranteed, you know, and it's like maybe that could happen to you. I have found by and large this is not a big issue for most of my patients, because most of my patients, let's say who are men, don't desire pregnancy. That's a very feminine thing to do that would feel very uncomfortable to them. So most of my patients don't want to retain their fertility. The other part of your comment, I think, was about, were you talking about more like detransitioning, people who regret transition, or people who've transitioned and are still having, still feeling some discomfort in their new, still feeling some discomfort in, and that's where I think about like the readiness for change, right? And so I talk with people who just about all the different elements that are involved with transitioning. So I say, like, you know, you're going to transition, but your whole family around you, like everybody around you is going to transition and then like accept this new person. And so for some people who have dealt with a lot of rejection, right, or poverty, or feeling loneliness and isolated, or maybe they're in between jobs and they don't have money to take off time to have top surgery. And there's just there's a lot of different variables to be considered. And one thing I always remind people is there is absolutely no emergency. Like there's no emergency to transition. It's not something you have to decide and lock in stone like immediately right now. Like take some time and really figure out what's the best path for you.
Okay.
Yeah, and working with behavioral health providers, I think, who have experience with this are extremely valuable. Extremely valuable at helping people through those different levels of care and transition. Transition is usually, so you're an OBGYN, you said, I think, right? It's kind of like
I had OBGYN background.
That's your background.
Sorry?
So I compare it often to pregnancy, right? And childbirth. Like usually we think of it as like a happy, positive time in somebody's life, but it's not always. And there's a lot of aspects of it that can be very stressful. I'm just using that as kind of a random analogy, but there's aspects of it that can be really unanticipated perhaps, or that can be really difficult and stressful. So like changing your whole identity and how people will see you at your class reunion or in your workplace or in your apartment building. Then something that's been very, very private suddenly is very, very out there, and people see this change and people ask you to explain yourself, and it's a lot to go through. So yeah, there's a lot of different levels, I think, and a lot of different aspects to transition.
Yeah.
Those are really insightful. Yeah. Insightful
Thank you.
Observations. Yeah. Yeah. Thank you for those.
Thank you. Yeah.
Oh, I see another hand up. Is it Falake?
Yeah, thank you, Falake.
Yeah.
Yeah, thank you, Dr. Deshain. That was really wonderful presentation. My name is Falake. Yeah, coming from my background, I know this is something that we don't really talk about. So I know, based on your experience, for parents who are not supportive of this accepting their kids gender dysphoric, what are the things that you've done in recent times to make them accept these changes that kids are experiencing?
How do I work with families to help them accept their child? A lot of it is just spending time with them and initially just listening and trying to understand what brought them to my office, right? Because I do get a selected group of patients, right? The patients who I see are people who have made an appointment, right? So that certainly like selects people where at least there's some willingness to come in and have a conversation about it. So the people I don't see, I think, are probably struggling more in terms of getting that support. So I have I'm thinking of a particular family. I don't want to like divulge like specifics or anything, but where the parents were very concerned about their child's depression and suicide attempts, and also for personal and some religious reasons, they felt very uncomfortable with this idea of transition and that their child's gender could be different than what they thought it would. And so they were really struggling. But what we looked for was just what I looked for was that common ground, right? And the common ground that we had was we all wanted what was best for the child. We wanted the child to survive and not be readmitted to the emergency room or to a psychiatric unit for severe depression or another suicide attempt, right? And we all came together on that. And I did not even, we really didn't talk about hormones or medical intervention at the beginning. We were really just sort of getting to know each other and gain their trust. And the child was the one that was really adamantly pushing for medical intervention, very, very, very strongly. And eventually, I think the parents came to understand that whether they agreed with it or not, their child was going to transition at age 18 when they could legally make the decision for themselves, or at a younger age. And so we had a conversation once of like, you have a decision to make. Like you can, like, in my opinion, as a medical professional, your child is male, right? Your child is transgender. It's very clear. They meet all the diagnostic criteria. I really don't expect that's going to change, right? So you can love and support this child for the next several years until they're an adult, and have a lot of conflict and risk and depression. And your child is going to probably continue to want to hurt themselves because they feel so strongly about wanting to transition and present themselves as they feel comfortable. Or you can support them and allow them to transition and potentially reduce that conflict. And either way, you're going to have a transgender child as your child. And that part of it is not going to change. What's going to change is when the timing of the transition and whether it's sooner or later, and what happens in the interim. So that's how I've approached it. And I think just trying to have a lot of humility with that. And obviously I'm very supportive of my patients, but trying to understand where the parents are coming from, because usually you can find it's coming from a place of fear that their child is going to be seen as different or hurt, or maybe this isn't the right thing for them. But it's fear and love. It's fear of what's going to happen to my child if I allow them treatment, but also fear of what's going to happen to them if I don't allow them this treatment. So just trying to understand where they're coming from. And usually the ones that are hard are the parents who don't come to the appointments, where you don't have that opportunity to have a conversation with them. Or maybe a divorced household, for example, where there's one parent who is involved in the other. There's some difficult cases. I will say that's not most of my patients. Most of my patients have good support. Thankfully. I should knock on wood after saying that.
Thank you.
Yeah, you're welcome. That's an excellent question. Yeah.
Thank you.
Any other questions for tonight? Doesn't
Just
look like it. Go ahead.
a quick one, not related to the topic or probably somewhat tangential. So does any of the programs, particularly in Pennsylvania, have like a curriculum introduced in their programs for LGBTQ health or maybe gender affirming care?
Family medicine residencies?
Uh-huh.
That's an excellent question. And I wish I knew exactly the answer to that. So I am building that at our residency program. And we certainly provide that care in our system. And so we can set up experiences with that. We don't have a formal rotation in that now. I'm working on it. I think in some of the bigger cities, it's probably more likely that they would have that. Like the Children's Hospital of Philadelphia has a pretty well-established like gender and sexual wellness center, where a lot of children go, in the more urban areas, and the Mazzoni Center, which is also in Philadelphia, where it's harder to get those services in the more rural areas. And that's why we're working, because the patients are here as well. They just have less access.
That's a good start. Efforts matter, I guess.
Yeah. Thank you all for all, like, I'm thrilled to have this opportunity to present, but I am so pleased with the engagement and the excellent conversation we've had, like after my slides. So thank you guys for showing up and being thoughtful and interested to have this wonderful conversation. I really appreciate it. I'm inspired.
Well, thank you, Dr. Frank Dixon. That was really wonderful. And it's just so exciting to hear about what you're doing, especially at a rural location. I think that's really great. So if there aren't any other questions, I just want to thank Dr. Frank Dixon again and the Geisinger Lewistown Family Medicine Residency. Glad you could join us for this. And thanks to everyone for signing on tonight.
You're welcome. Thank you.